Okay, so the poster that I'm going to present is about formulation development for brain delivery. And I want to frame the problem a little bit clearer than it's maybe outlined on the poster. So we all know delivery intravenously with a long, not cannula, but how is it called? I'm missing the words here. Infusion line, here we go. So with an infusion line into the vein, and to get AAV or anything else into the brain, you could modify your vector so that it naturally goes into the central nervous system. But sometimes what you want is really local administration into the brain. And the way you can do that, what is the enabling technology there, is a company who developed a very long, very thin cannula that really goes directly into the brain. And I have something here for you to see how this cannula actually looks like. It comes in such a box. And in the inside, I've got a dummy here, which isn't as long, but it gives you a sense of how long and how thin, not actually how long, but how thin this needle is. You can barely see it. Maybe if I do the focus bit, here we go. So it's only the tip at the very front that goes into the brain. And this is being used for brain delivery of AAV. There's also, in fact, one product approved that uses this cannula. It's called Cabalidi in the US, and in Europe, it's called Upstaza. And what it does is it essentially delivers microliter volumes of product into very localized areas into the brain. And this is all done live during the patient being lying in a MRI, so you can, with a contrast agent added, actually see how you deliver the dose. So this is all very interesting, but I pointed out that the cannula is very long and very thin now multiple times, and you can see where the problem already is. If you pass a product through a long cannula, the surface area to volume ratio gets so large that you have to consider if you have losses just to that, losses of your dose essentially to that inner surface of these cannulas. And this is what we actually observed, and this is the problem. There's one approved product. There is more than 10 products in clinical phases that are publicly disclosed, and there are over 60 in preclinical phases. So there are a lot of companies that use these types of cannula and localized brain delivery. And in fact, some of them are our customers. And yeah. So with that appropriately staged, I'll switch over to sharing what we actually discovered and also a solution to it. So this is what the poster looks like. I'm going to zoom in now so that we can go through it step by step. You already know this part. I tried to make a picture of a very, or pretty long and extremely thin glass cannula. So the inside of this cannula is indeed made of deactivated fused silica, which is a fancy word for glass. It's 3 meters long, and the product is being pushed by a syringe pump through this cannula, and the patient is in an MRI while this is happening. And as I said before, what we observed for a couple of our customers is that there are significant losses to the surface area of this cannula. What that means is that you lose a large part of your dose when you pass the product through. And how this looks like is shown essentially in this panel. So what we did was we passed product at a clinically relevant concentration, which was about 2E12 Vg per ml. We passed that through the cannula. And after we took fractions after 50, 100, 150, 200, and then in 100 microliter steps, 300, 400, 500 microliters, and assessed the content of DNA that we could find in these fractions. And we observed that within the first 50 microliters, there was essentially nothing. and only after 200 microliters, we observed that slowly DNA is actually, or basically vector is coming out of the cannula. And what we also observed is it kind of overshoots a little, because we also measured the product before it was passed to the cannula, and this was basically the 100%. So what we observed was the severe titer loss without a surfactant being used, especially in the early fractions. The recovery later on improves after progressive surface saturation. So what we realized was we have strong adsorption to the cannula, and we and also our customers realized we need a little bit of surfactant optimization. So we just add a little bit of, let's call it soap, to the formulation in order to prevent any surface adsorption. We also ran DLS with the eluted volumes, and indeed we couldn't see anything that was remotely close to an AAV peak in the first 200 microliters. Only after 300 microliters, the device was able to see a peak in an approximate range, but it varied a bit as well in the later fractions. So basically, in the first 200 microliters, also DLS told us there was nothing in there, and this mirrored the qubit data. What I can say on this call as well is this also mirrors quite closely the data that we observed with customer samples. These were the product that we tested here was an in-house preparation, but we saw with multiple customers now that there are losses to the cannula in the first 200 microliters. What is very problematic with this behavior is that the dose volumes that are, for example, used in the one approved product, the dose volume that is being given to a patient is 320 microliters. So this is well below what we saw is necessary or required as a flush volume that you might need to consider if you want to administer the dose correctly. So I wonder, or I hope, that the company behind this product did an experiment like this in order to assess if they dosed actually the correct amounts to the brains of patients. So, but what can you do? I outlined it before. You can add different surfactants. We tried 3 of them: Poloxamer 188, Polysorbate 20, and Polysorbate 80 in different concentrations. Let's look at the data from the Poloxamer. It's a widely used surfactant. It's actually also being used in the product that I just mentioned, but at 0.001% weight per volume. And what we observe here is that addition of a little bit of surfactant marginally improves the situation. We again observe this overshoot, and this behavior, we have observed this actually multiple times, and we coined it, drop, I forgot how we coined it, apologies.
Drop pop.
Drop pop. Oh, it was so memorable, and I forgot it. This is a testament to how good I prepared, unfortunately. The drop pop, yeah. Thank you, Sonja. So, we see initially a drop in dose, and then it pops and we think this behavior is basically this is rinsing out the adsorbed AAV. So we've first got a drop and then a pop. This behavior gets less pronounced if you increase the Poloxamer content to 0.025%, and the recovery is, I would say, acceptable at 0.005%. This behavior is also same behavior is also seen when you look at the DLS data. I displayed it here as a heat map, so whenever you see a non-Xed cell here, then the device could actually measure something, and the number that is displayed in each cell is the average diameter of the preparation. And actually, Poloxamer did a really good job with providing monodisperse samples from a product that initially didn't look so good without the surfactant. So in this regard, Poloxamer 188 was really good. Wasn't as good in actually improving the outcome. Here, if you compare it to the Polysorbate samples, and this is shown below. Just exemplary, the Polysorbate 20, we have acceptable recovery at very low concentration. So at 0.001%, this is the panel here in the middle. If you compare that, or it is roughly comparable to the panel here with Poloxamer, 0.005%. So you could say it's 5-fold more efficient. I'm not sure if I would say it this out loud like this. But it looked, at least for us, it was very surprising that the polysorbates actually behave better. We were prepared for that you would have to use more polysorbate than Poloxamer. This is why the concentrations that we tested are a little different. So we tested the very low concentration, then intermediate concentration, and then a high concentration, which is 0.01. But actually, we should have, in hindsight, gone with the same concentration levels as the Poloxamer 188. From a nanoparticle perspective, Polysorbate wasn't as good as Poloxamer in giving really a uniform formulation. It varied a bit. So this is something you would have to definitely look into. We see some variation here at the very lowest level, although the recovery was okay. The size distribution didn't look as good in all of the fractions that we collected. We saw basically the same behavior with Polysorbate 80. So good recovery already at 0.001%, but some incoherences with the DLS. So you'd definitely have to take a closer look at these formulations if you're using Polysorbate. Gives you better recovery earlier from the cannula, but you might be paying the price with incoherent uniformity of the formulation. So all in all, I won't go through all the results and the conclusion, but I think you got a fair picture of what I wanted to stress with this poster, is that companies who use these kinds of cannulas really need to take good care with formulation development and have a close look on how much actually of that dose is being delivered through the cannula. You might imagine that sometimes 2 areas in the brain are being treated, and if the first treatment area gets the first 160 microliters of the 320 microliter overall dose volume, but nothing is in there, and then the surgeon pivots to the other area in the brain and injects the next 160 microliters, and all of a sudden this volume contains double the dose of what you originally anticipated, then the distribution is not what you intended. So what we want to do, or want to raise awareness with this poster, is to our customers and possible customers to invest a little bit more in formulation development before they go into any tox studies and potentially, of course, human studies. And with that, I'll leave it here. I'm scheduled to show or present at ASGCT a second poster about downstream development regarding the AAV8 full empty separation, but due to time restrictions, I hadn't completely practiced the talk about that yet. So yeah, we'll have to show that at another time. And with that, I want to end it, but also want to thank everybody who supported with the generation of that data, namely Christiane Mummert and Sonja Schermann, and also Florian Dunker for his thorough review and help with the qubit data.